there. So let's talk about digoxin today. Is it a superhero? I think that there might be a pretty good argument for that. Digoxin or lanoxin has literally been around the drug cart forever, maybe even longer than forever. And it is still hard to beat. Plus, it is super cheap. So that makes it really nice for patients that are on limited budgets or don't have drug plans and that sort of thing. And it does a great job. Dig is both a positive inotropic as well as a negative chronotropic drug, which means that it is used to increase force of contraction. That's what we're using it for. With Dig, we're going to accomplish a couple of things, several things. One, we're going to increase that contractility or the force of that contraction. By doing that, we are increasing the cardiac output, how much output the heart is actually able to do, because we've increased the contraction itself. And then also it is decreasing the heart rate. So it does those three things. Sometimes Dig is called an atrial kicker, which means that it gives the atrias just a little extra bump, just a little extra kick at the end of the contraction of the atrium, so that all of the blood actually gets out of the atriums with each contraction. These patients will most certainly be on multiple medications and probably anticoagulants, especially if it is after a cardiac event like they have after a MI. They're going to be on an anticoagulant. Warfarin, Coumadin is still widely used. It's definitely one of the most popular ones out there still. Oldie but a goodie. Dig, what you need to know about Dig. Always, 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 did I say always? Always monitor your patient's heart rate. And we're talking the apical heart rate, which means you got to take your stethoscope, put it in your ears, you got to go in there, you got to put that stethoscope on their chest and actually take their heart rate prior to giving the medicine. Too late, once you've given that pill, you cannot get it back out. If the heart rate is less than 60, you are going to hold. Did you hear me? We're going to hold the medication. Don't forget that. I can tell you I have seen that everywhere. Definitely probably going to be somewhere along the way on the NCLEX. And if it's important enough to be on the NCLEX, it's probably important enough to be on a quiz or a test or something like that along the way. So just remember, Dig. Heart rate, always going to check it. You want to check it within 30 minutes of when you give the medicine. So what that means is don't take a 7 a.m. heart rate and then 2 hours later at 9 o'clock get ready to pass your 10 o'clock meds and go and give Dig because the heart rate was good at 7. You want to check that and always make sure that within 30 minutes of giving that med that you've checked the heart rate and it is higher than 60. Dig is designed to lower the heart rate and enable for a nice full contraction of the atriums. So if the heart rate is already less than 60, we don't want to lower it any further because the further down we go, it's not going to be a good happy ending for this patient or for you for that matter. Next, about Dig. You want to monitor your patient for Dig toxicity. That's another one of those really popular NCLEX questions right there. Monitoring the patient on digoxin for Dig toxicity. Well, you got to know what's normal, what the normal therapeutic range is for Dig in the blood to know if they're getting near toxic. So normal range, write this down, 0.5 to 2 nanograms per milliliter. If your patient starts reporting to you that they're seeing little yellow-green visions and halos around things, you need to beware, you need to look out. That's a definite sign of Dig toxicity right there. Toxicity a lot of times can be caused or be linked to the fact that this patient is probably on multiple medications like diuretics, especially those loop diuretics, Lasix, that we like to use so much. You know, they're going to be on these multiple meds, and if their potassium is down, the chance of Dig toxicity goes up. So if they're on loop diuretics, which are non-potassium sparing, that means the potassium goes out too in that potty, then their chance of Dig toxicity is increased. So you need to be assessing this patient all the time. That's because Dig toxicity is a pretty serious thing and can be fatal for your patient. So beware.